Okay, good afternoon, everyone. Welcome to our 2 o'clock briefing. Pediatric cancer treatment comes to crisis zones. We have 3 wonderful speakers with us today. Dr. Sima Jeha, pediatric hematologist-oncologist, and the director of the Eastern Mediterranean region at St. Jude Global, St. Jude Children's Research Hospital. Dr. Rhea Saab, acting director, Children's Cancer Institute, and the director of pediatric cancer research at the American University of Beirut. And Dr. Regine Kaboudi, professor of pediatrics, pediatric hematologist-oncologist at Istanbul University, Cerrahpaşa, Istanbul University of Oncology Institute. And we'll get started.
Good afternoon, everyone, and thank you for being here. So we will be talking about childhood cancer this afternoon and how collaboration between different centers and countries improve the outcome. And why is that important? It's important because childhood cancer is a very curable disease when there is adequate access to appropriate diagnosis and good clinical care. In higher income countries, the cure rates exceed 80%, so most children diagnosed with cancer survive their disease. Unfortunately, around the world, children with cancer still die from their disease. It's because the global burden of childhood cancer is dramatically shifted toward countries with limited resources. So to help improve this gap, St. Jude Children's Hospital have initiated the St. Jude Global program, which is really built around the premises that together we are stronger. So this program is creating networks of different alliances that work together to provide access of good quality care to all children with cancer, no matter where they are. And you can see on the map the different regions where we have alliances in and networking for the sake to improve the outcome of children with cancer. Now, of course, we do this through what we call the pillars, which is education. So we train the workforce on the ground so that they are expert in what they do. We also create patient-centered national and regional programs, and we develop research infrastructure to sustain a continuous improvement in the level and quality of the care that's delivered. Of course, with every initiative, sustainability is key. And the war in Syria have really tested our network. As you know, the war in Syria has resulted in the largest humanitarian crisis since World War II. And although the news covers mostly the waves of refugees in Europe or North America, really most of the burden is falling on the neighboring countries that have very limited resources and are dealing with their own crisis. Lebanon and Jordan are 2 countries that have the highest number of refugees per capita in the world, and Turkey is leading in the absolute number of refugees that it accepts. So sharing the panel with me will be Dr. Saab and Dr. Kaboudi that will discuss how their countries, Lebanon and Turkey, are dealing with this crisis. And in particular, Dr. Saab will discuss how a long-term collaboration between St. Jude and Lebanon have assisted hundreds of children that were displaced during the war and who would have died just because they developed cancer when the families were displaced. Because of the success of the program in Lebanon, St. Jude initiated a similar program in Jordan last year. But most importantly, what St. Jude is doing is building capacity in the areas that are affected by conflicts, such as Syria, Yemen, and Iraq. And the reason to do that is to take care of the children that are left behind in those countries, and also, and most importantly, so that when the crisis subsided and the refugees go back home, there is an infrastructure to take care of them, and they don't stay behind in the countries where they currently are. St. Jude recently received the designation of the first center for childhood cancer partnering with WHO. So this partnership between the WHO and St. Jude is very important to push both organizations to work towards advocating for childhood cancer and further improving the survival and decreasing the discrepancy between the survival among different countries, higher income and lower income. So we are very excited about this partnership, and we feel that it will energize our current initiatives. Thank you.
With the start of the refugee crisis in Lebanon, that started around 2011 with the influx of the Syrian refugees after the start of the war in Syria. Our unit in Lebanon started seeing more and more patients come to us to seek care with a very minimal support. And this is where the collaboration with St. Jude, the pre-existing collaboration with St. Jude, as well as the setup of the cancer center in Lebanon, took the initiative to address that crisis and to try to learn from that as we go along regarding the best way to address this increase in demand for medical services without adequate financial support. Currently, Lebanon hosts the largest number of refugees per capita, which is primarily Syrian refugees, but also includes Palestinian refugees that have been living in Lebanon now for years. And more recently, we have also been seeing more and more Iraqi patients coming to seek medical care because of the complete lack of infrastructure after the successive wars in Iraq. This ended up causing a stress on the infrastructure that was already available to treat children in cancer within Lebanon because of the rapid rise in numbers that almost doubled. The Children's Cancer Institute in Lebanon was established in 2002, actually as a collaboration between St. Jude Children's Research Hospital, the American University of Beirut, and the Children's Cancer Center Foundation that primarily raises funds to treat children with cancer so that no family would pay out of pocket to treat their child with cancer. And currently, we treat about a third to 40% of pediatric cancer cases in Lebanon. So when the Syrian crisis started, and with the increase in number of refugees who were seeking care without any financial coverage from any governmental or non-governmental institution, because the majority of the aid that was given to refugees or to support refugees, whether by the UN or by other governmental or non-governmental organizations, was focused primarily on taking care of the basic needs for daily living, as well as communicable diseases, with very almost non-existent support for cancer services. So this is where we set up a series of initiatives that were set up as a collaboration between St. Jude Children's Research Hospital and ALSAC in Memphis in the USA, the Children's Cancer Center Foundation in Lebanon that raises funds to treat children with cancer in the country, and the American University of Beirut. And this was done through utilizing the network that we already had with local and regional hospitals, as well as local smaller NGOs. And we set up with a series of initiatives, with learning from each initiative regarding how to approach this crisis. So the first initiative was primarily a collaboration among the local NGOs to be able to raise enough funds to treat those patients who were coming to our hospitals without any source of support. The second initiative was to allow access of those patients to specific funded disease-specific programs. So programs to treat, for example, children with specific types of leukemia, specific types of solid tumors. So we opened that up to refugees as well. And the biggest initiative was the third initiative, which is a humanitarian response program that was done among those three institutions to allocate and earmark specific funds for the treatment of refugees. And that way there would not be allocation of funds away from patients who are already within the catchment area of the program, but rather we would build upon that. Currently, we're expanding that in collaboration with St. Jude more to a regional approach to the humanitarian response, especially with the movement of refugees across different countries in the region. We have been able, through those programs over the past 8 years, to increase our ability to absorb treatment for those patients from treating less than 20% of children who presented to us to now treating more than half of those patients. We are still, through the allocated funds, and because of the magnitude of the problem and the magnitude of the crisis, we still have some challenges regarding being able to treat every child with cancer. Currently, we treat about half of the patients that we see, and the rest we try to secure places for them where they can receive some form of treatment. And the range of cost of treatment really ranges from around $10,000 for the minor procedures to up to $120,000 per patient for the duration of their treatment. We have learned a lot from these programs regarding prioritization of the use of resources and the excellent outcome of patients who do get treated, which is similar to patients who are not refugees. But we know that we still have faced limitations in financial resources, in having enough infrastructure and capacity to accommodate the almost doubling of the number of patients over that period of time. And of course, barriers that this population has in seeking continuing medical care, especially with the poor living conditions and the competing basic needs. We hope that with what we have learned from these successive initiatives, we will be able to provide a sort of a roadmap that can help in planning ahead for this sudden increase in influx of patients, and that really builds on the collaboration between the private sector, the community, and academic institutions.
I'm Rajin Keburi from Istanbul, and I'll talk on the impact of the refugee crisis has had on the health systems, in particularly focusing Turkey and pediatric cancer. As you have heard, the number of displaced people and refugees is increasing worldwide and in the Middle East due to conflicts and war, and cancer care, it is affecting cancer care along with many other healthcare services. Well, as we have said that 50% of the world's refugees are children. This means cancer care causes a substantial burden on the health system of these host countries, but also childhood cancer is a major challenge. Turkey worldwide currently is hosting the largest number, the highest number of refugees, with 4 million refugees, 3.5 million of whom are from Syria, and the rest from Afghanistan, Iraq, Iran, Somalia, and other countries. And this is a huge number, as you can imagine. And when the crisis began in March 2011, so hundreds of Syrian refugees were coming from the border, then it became thousands, and then 100,000, and a million, and then today it is 4 million. What were the actions that were taken by the authorities? In 2011, the Disaster and Emergency Management Presidency, called the AFAD, which was activated for emergency situations, promoted ordinary daily life, education, and health services. And in 2013, the law on foreigners and international refugees was put forth, and the Syrians were given the status of under temporary protection, and they were given ID cards, which these ID cards provide them access to free public services, including health services. And in fact, of note in Turkey, after the health reform in 2000, there has been quite good improvements in healthcare, and all healthcare is provided free of charge for all children under 18 years of age and to adults as well. So from this law on, all the Syrian refugees and other refugees could also get free medical care, whatever their disease was. And of course, this has brought quite a financial-wise and capacity-wise a big burden to the country. Just to imagine until 2015, $7.5 billion was spent for refugees. 1/3 of it was spent for healthcare. And in 2011 and 12, in 2 years, there were about 9 million admissions to any healthcare services by the refugees in Turkey, which had cost about $340 million. And the cancer care, of course, was the most costly among these. And in Turkey, according to the Ministry of Health, the data of the Ministry of Health, in 4 years there were 40,000 cancer cases in all ages registered within the refugees, Syrian and others, but most were from Syria, in Turkey. And 17.5%, almost 7,000, were children and adolescents. This is a huge number because when you think of it, only about 4% of all cancers in developed countries or even developing countries are in children. But here, the children population and the adolescent population was huge, and the number of childhood cancers was quite high. And in Turkey, which is a middle-income country, at the moment, as I said, it is all free. The medical care is all free, and we have a cure rate in childhood cancer of 65% in the whole country, and about 74% in special centers like in my center. So all these children were treated free of charge as the Turkish citizens. So I and my colleagues conducted 2 different studies in 2 time points, before 2015 and the recent one after 2015. The previous one we have published in Lancet Oncology in 2016, to see the demographics, treatment, and outcome in these children, in the refugee children with cancer, and also to analyze the problems that were encountered both in the families and the healthcare personnel. And what we have seen was that, we move it this way, yeah. Here, yep. And what we have seen that most of these children, 90% were coming from Syria. Most had advanced disease, more than 70% had advanced disease, some had relapse disease. There was a male predominance in both studies before 2015 and after 2015. And all the 3 most common malignancies that we see in the refugee children were leukemia, lymphoma, and brain tumors, which were the same as we see in Turkish children. And also the encouraging was that the outcome, when we matched it with the stage, was about the same in the Turkish children. So when they were provided with good medical care, these children could be cured or could get good treatment, and the outcome could be the same. Of note, how do I go back? This one? Okay. Of note here, some cancer types were in higher frequency in the Syrian population, like the neuroblastoma and bone tumors. These needed more sophisticated and expensive, technically sophisticated techniques for treatment, like stem cell transplantation or limb-sparing surgery, avoiding amputations. And we saw that these were more frequent in the Syrian population, which made us speculate maybe they were coming when they had this kind of disease, being the ability to have this kind of medication and free of charge was one of the reasons for them to coming even earlier. And so coming to the problems that were encountered before and after 2015, the problems can be summarized as housing, shelter, communication problems, language barriers. In Turkey, the language is Turkish, and they were speaking Arabic, so there were a language barrier, communication barrier, psychological problems like the burden of being a refugee, the burden of coming to a new country, burden of having a child with cancer, diagnosis of cancer, and compliance with treatment was also bad. What we have seen in the last survey that although these problems still are a problem in the south and southeastern part of Turkey, where half of these children are treated, in the children that were treated in Istanbul, where 500,000 refugees reside in Istanbul, in fact, which is part of it is in Europe, as you know, from Istanbul. There was improvement in housing, in compliance with treatment, and in communication problems. And these families who have been residing in Turkey for a longer time, which makes us think that there is, if not all, somewhat an integration to the community, which is good for these children when they are treated. So in conclusion, if the childhood cancer is a curable disease, and if we can diagnose them early and treat them appropriately, these children can be cured, whether they are refugees or not. And all children need health care equal, without disparities, these children also. And we shall know that all in refugee settings, the nations have to be very rapid in the actions to be taken, strategic actions to be taken. And we need international collaboration between governments, non-governmental organizations, and healthcare organizations to improve the need of these children and other children worldwide. And I would like to conclude saying that February 15, yesterday, was the International Childhood Cancer Day. And in International Childhood Cancer Day, we all pediatric oncologists want to say that no child should die of cancer, especially because of disparities. Children are our future. Thank you.
Thank you so much. Okay, now we'll take questions. Please raise your hand if you'd like to ask one. We'll bring a mic to you, and kindly state your name and affiliation before your question. Okay. All right, so we have a question here.
This is Amanda Johnson from AAAS. Do you think we may see a sizable increase in the incidence of pediatric cancer cases globally as a result of children having better access to quality health care who otherwise may not have sought treatment?
Actually, that's a very good question, because part of the problem globally is a lot of children, like 80% of the children that live in middle and low-income countries, do not even reach the stage of being diagnosed. So for instance, if you look at some registry, it shows that some countries do not have brain tumor or very low incidence of brain tumor, but the reality is that probably those kids never reach a physician or a clinic to diagnose them. So part of St. Jude Global task is to ensure registries to centers that we are working with. So this way we increase the access to diagnosis first and then to care, but also we keep track of the number. So as you mentioned, as we increase the access to care, there is no question the diagnosis will increase because we are reaching to those children instead of them dying from cancer without even being diagnosed.
Okay, question here.
Hi, this is Val from AAAS, and I have a question. You guys have created this roadmap of how to address this healthcare crisis, and we see now in Latin America there's another refugee crisis who is facing very similar challenges in terms of language barrier, even cancer patients. Have you thought about writing any guidelines so other regions can look at what you have done, and then perhaps they can copy that to address this issue in a faster way?
You would like to?
Yes, definitely. I think this is an opportunity for all of us to learn from the initiatives that have been done in countries that have received refugees. And as you can tell, the response of the different countries, the response in Turkey, the response in Lebanon, and in other countries like Jordan, have utilized different mechanisms and different approaches with specific challenges, successes, as well as failures in each situation. We are compiling this information. We've recently published our experience for the first 6 years of the crisis in Cancer Journal. And our colleagues in Turkey, yes, have also published that. Regine can talk a little bit more about. And over the years, we have had to tweak our approach quite a bit, and regarding resource utilization, regarding prioritization of resources, and the way of engagement between the local oncology networks, pediatric oncology networks, as well as the different NGOs that are working in the region. And I think this is definitely something that we are interested in putting together and putting forward as an example of what can be done. And looking at the different experiences with the differential involvement of government in the different areas can also help sort of set up a roadmap for the different ways that these problems can be tackled.
Yes, this is an important question, and the analysis of what has been done in these countries should help future responses in these resource-limited or even resource-rich countries with refugees. As Raya has mentioned, she has published her experience in Lebanon, and we have published the situation before 2015 in the refugee children with cancer in Lancet Oncology in 2016, and now we'll have just compiled the data, the new data after 2015, so that we can publish it. And also in Berlin, a year ago, or 1.5 years ago, we had two different meetings in where people from Middle East and people from Europe came together to discuss, because as you say, the experience that has been gained is a huge experience, and it has to help other countries as well. And the responses have not been the same in all countries, even in European countries, although the number of refugees was much less than that have been experienced in the Middle East countries. And also there, even in the United States, a medical doctor from New York gave a very good speech and compiled all the data about it, that in New York and the United States also there are so many refugees, registered or non-registered. So, of course, the problem is worldwide, not only in the Middle East, but we're facing it in the Middle East more than the others, yeah.
Your question is a very good one about having guidelines to address crisis. And I would like to expand on what was said, is that there are guidelines for communicable diseases that have really worked, and we know what to do if there's an epidemic or a viral infection, and those were learned, and now they are available, and people know how to address them. For non-communicable diseases such as cancer, there are no such guidelines, for the simple reason that those are more complex, they require a multidisciplinary approach, and they are more expensive. But now that we are learning how to better control communicable diseases, the burden of the non-communicable diseases is increasing. And we are showing that we need networks that can act in case of crisis. And I would like to add here that those guidelines are important because it doesn't have to be a refugee crisis or a man-made crisis. You can have a tsunami or a natural crisis that displaces population even within a place like the US. Those networks are very important to learn how to communicate and connect and then save those children. I'm talking about children. It can be other non-communicable diseases, but we have shown that children with cancer are really curable, and it's important that they stay on track and schedule for the treatment. So, yes, we need a roadmap to know how to approach those crises, whether they are man-made or nature-made, and then keep the outcome of children without compromising their outcome.
Another question here? Yeah.
Amanda Johnson from AAAS. Is treatment in these crisis zones mainly standard of care, chemo, surgery? Or are you looking at newer classes of drugs using those, like immunotherapies, CAR Ts, checkpoint inhibitors?
So in Lebanon, the treatment that we decided to offer through the humanitarian response program is exactly the same treatment that we offer to Lebanese children living in Lebanon. This is, in most cases, standard of care therapy with advanced surgical radiation techniques, immunotherapies, CAR T cells. A lot of those are currently still not available in the Middle East, and patients who need those would need to travel most of the time without any third-party coverage for funding, at least from their countries of origin. So the same treatment was given to the refugees as to the indigenous population, although some of those newer therapies are not available for either.
In case of Turkey also, all the Syrian or the other refugees got the same treatment that the Turkish citizens, Turkish children were getting. So all the standard therapy, chemotherapy, radiotherapy, surgery. And in cases where the immunotherapy is accepted by the Ministry of Health to be reimbursed. If it is reimbursed for the Turkish children, it was reimbursed for the refugee children also. But as Raya said, for example, for CAR T cells is not standard practice at the moment in Turkey. But for example, stem cell transplantation is, and in the last study that we did, there were 41 patients that had stem cell transplantation, and the outcome was over 50%, which were all high-risk patients. So they could be treated, and the surgical technique, surgeries could be done in our techniques. Yeah.
Dr. Jeha, you mentioned, or maybe all of you have alluded to this, this being one of the, if not the first example of a global health initiative helping in a non-communicable disease setting. So what do you think are some of the next non-communicable diseases that are poised to be guided by this and maybe be treated with similar methods?
I think the fact that childhood cancer is so curable if it has access to good care, whereas it's totally fatal if there's no access to care, this disparity in survival is dramatic and is a good model to apply. But of course, this model can apply to any other non-communicable diseases and probably should be. So we hope that this that other people within their specialty will have similar networking and guidelines to improve the outcome. But it will have to take specialty to have this networking. We at Tenn we can only deal with childhood cancer because it's our specialty.
And you could actually see that being applied in the refugee populations in areas like mental health, for example, where there have been a lot of concerted efforts to address that. Different from diseases, education, for example. Again, a lot of concerted efforts within the hosting countries through NGOs and private organizations. So I think even not just with diseases, but with other aspects of the road towards healthy living, this can be applied.
Yeah, I think so. That, like the primary care, the vaccinations in the refugee population are also important. For example, by 2017, there were 300,000 Syrian babies born in Turkey, almost 300 per day. And all these need antenatal care, vaccination, which is very important. And for schooling, at the moment, there's 1 million Syrian children who are at school age, which is very important. Like in camps, 90% of them do go to schools, but outside camps, the percentage was lower. Now it has increased to 62%. And it has been estimated that each child has lost 2 years of schooling, the refugee children. So I think there are many examples that could be taken, that experience can be gained by this population.
Dr. Saab, you mentioned that you had to make, I think you said some tweaks, maybe some major tweaks you said, to guiding the oncology and working with the NGO. What were some of those that were most successful?
Because of the nature of the intervention, which really is earmarking a specific sum of funds, yearly funds, directed specifically towards this humanitarian response, unlike, for example, the situation in Turkey, where it's a governmental provided healthcare services, we had to prioritize the eligibility criteria, if you will, for patients to utilize those funds. So for our program, those funds were earmarked for patients who had newly diagnosed disease. And this we learned also from that over time. So patients who, for example, had started their treatment somewhere else or who had recurrent disease were not eligible to utilize that fund. We limited the treatment to, so we limited enrollment also for patients who required chemotherapy, radiation surgery, but not other specialized procedures like bone marrow transplant, for example. And we had to, so to figure out what to do with those patients, we had to develop networks with other NGOs who would be able to provide funds specifically for those particular patients. So, we shifted with time to actually intercalate with other NGOs to be able to have that sort of smooth transition of patients. We also learned that because of the limited infrastructure and the limited places with the increased number of patients, we developed a mechanism by which patients could get diagnostics at our center, and then we could refer them to other peripheral hospitals for the low-intensity treatment that they could get over there. And this would allow us to serve a larger number of patients. And then finally, now with the improvement starting to improve security situation in Syria, we are partnering with institutions within Syria that we have had a good relationship with to start building infrastructure and prepare for the next transition of care for patients when they're able to go home.
And in fact, in these children, even though they are like in Turkey, the government provides all the medication and the diagnostics and all that. Still, there are some gaps. Like, for example, I said one problem was housing, because some of the treatment can be given as outpatients, but these children could not be given, many of them, treatment as outpatients. So there were makeshift solutions like extending the inpatient stay, which cost more for the government, but it provides a better outcome for the children, where they can get healthy food and they have a clean environment. Otherwise, they can have infections in the places that they were residing. So there were quite makeshift solutions, and NGOs also help. The help of NGOs, I think, is very important in every country. Like, although you can provide the medication, they need clothing, they need some food. So NGOs do help in many aspects.
I imagine all doctors have challenges following up with their patients, but I'm wondering, particularly in this context, what were some of the challenges in following up with the children that you've treated over time and beyond?
So here again, this is another area where there might be some differences between the different countries. Lebanon is a relatively small country. You could really cross from one end of the country to the other in 4 hours by car. So it's a small country. So the patient's ability to come to the hospital and go back home, it's impacted primarily by financial resources, but not by distance. So for we expected at first to have some abandonment where patients would be lost to follow up or unable to show up for treatment, but we were surprised that this was actually not the case. And we learned, which actually makes sense, that once you give those families the type of treatment, a complete, fully covered financial treatment, they are very committed to see their child through the treatment to get to a positive outcome of cure. So actually, we lost almost no patient to abandonment or to early leaving treatment. Now, once we finished treatment of those patients, once those patients finished treatment and were in remission, we did not follow them up further just because of the high number of patients. Typically, in childhood cancer, we follow patients for 5 years after the end of treatment. For most of the refugee patients, about 3 months after the end of treatment, we discharge them from clinic just to make place for the incoming patients. So we don't have a lot of follow-up beyond that point. But very, very few patients had to interrupt their treatment. They showed up on time, they got their treatment on time, despite all the difficulties that they were living in and despite the lack of social networks in the camps.
The situation was almost the same in Turkey. When they are given good and free treatment, the compliance is good, and they come and they finish all the treatment. But after the treatment, in the follow-up, they may change the city, or some do travel to Europe. And for example, I gave an example to my colleague. Last month, a colleague from France mailed me whether I knew such a patient with an eye tumor, retinoblastoma, retinoblastoma is a rare disease in children. However, some centers we see them more, and because the child had said that they were coming from Istanbul. And yes, it was our patient, but the patient did not, or the family, they had not informed us that they were going to Europe. But it was good that the collaboration within us, the pediatric oncologists worldwide, is good, and so we could send all the data that we had so that they can follow the child.
Okay. Well, if there aren't any other questions, thank you so much to our speakers. That was wonderful. We really appreciate your time. Thank you. Thank you.